Hello, I'm Nyla Goldenberg from Functional Endocrinology, and here's my friend. Go ahead.
Hello, Katarina Grisha, functional medicine and internal medicine physician from Chicago. How
Hi.
are you?
I'm doing well, thank you.
Thank you so much for having me on.
Yes. So today we wanted to talk about hyperthyroidism and our experience with that in our patients. As a internal medicine, what makes you think about hyperthyroidism? What symptoms do you think people need to be aware of in order to recognize that they may have overactive thyroid problem?
Yeah, absolutely. And actually, is one of my patients that this is how she presented, and she was having palpitations, really heart racing, and but she never measured, so she didn't know how fast her heart rate was. And was having headaches. So her blood pressure was increasing, and she was losing weight. She was very happy, actually.
I
I'm
bet.
losing weight. I can eat whatever I want. But so that can deceive patients, right? People, they would think, oh, I'm losing weight. I'm doing great. I can eat. My metabolism changed. It's fantastic. I don't want to go to the doctor. I don't need to go to the doctor,
Yes.
right? So, but then when the headaches would not subside, that's when she finally came to me, and we found out that she is hyperthyroid. And we did all the tests and found out she does have Graves, and uh, started on a journey with medication and diet,
Mhm.
absolutely. And then, of course, when people correct their thyroid function, right, their metabolism is not as fast, so they start gaining weight. But
Yeah,
that's why diet is so important, right?
absolutely. Yes, I see that all the time because when you reverse that overactivity, the metabolism slows down, the weight comes up, and people are not as happy. But depends. I have very severe cases of hyperthyroidism in my patients, and when they are being treated, they will feel so much better because on one side, yes, you are losing weight, you can eat everything. On the other hand, people have so much more anxiety. They cannot
Mm-hmm.
sleep, their hands shaky,
Yeah.
they feel hot, and that can make them pretty much disabled. Some of people, I had to write them down off of work for a month or two until their thyroid cools down. And when it cools down, that's when they start feeling better again. So there is always that trade-off that I see. Yes.
Right, right. So what tests do you do? Because a lot of the patients that come to see me, they don't have the whole panel, the whole thyroid profile from previous test results. Which ones do you run?
Yeah, so of course we run TSH, free T4, free T3. Interestingly enough, if hyperthyroidism is bad enough, free levels could be sky high and may not be measurable. So the total levels may need to be run in that case. But of course, you want to know why people have overactive thyroid. And therefore, I would add sedimentation rate because in some cases, it's just inflammation of thyroid that will temporarily release the thyroid hormone. And in those cases, neck frequently is tender, and that's your thyroiditis cases, and their sedimentation rate will be high. But that's temporarily for 6 weeks or so, and then they go into stage of underactive thyroid and may recover or not recover. And because of that, that inflammatory marker is very important. Plus, of course, if you are worrying more about autoimmunity, like Graves' disease, you would want to run antibodies, and you want to run all four of them. Hashimoto disease-related antibodies, which is TPO and thyroglobulin, and Graves' disease-related antibodies, which will be TSIS and TRAbs antibodies. So those are blood tests that you run, and then you want to do ultrasound and a radioactive iodine uptake and scan. Occasionally you do technetium scan, but I do prefer radioactive iodine uptake and scan, because that can give us great understanding what is the cause of hyperthyroidism. Is it, as we mentioned before, destruction of thyroid? Then the uptake will be technically zero because there is no tissue to uptake the iodine. Or there is a hot nodule which will uptake the iodine in one spot and it will be hot nodule there. Or it will be grossly enlarged, as is the case with Graves' disease. Very rarely, and I haven't seen personally the case, but cases I described when hyperthyroidism will be because of tissue in ovary. There are certain tissues, certain tumors in ovaries that can create exactly the same condition, and that's when, again, a radioactive iodine can be helpful, but it has to include not only neck, but the abdomen and whole body in a sense. So yes, those are rare cases, but very interesting.
Yeah, I've never seen one of those either.
Yeah.
Yeah, it's very rare. Yeah. Super. And then when people ask you, okay, what should I eat and what should I not eat? What do you advise them?
So we have to recognize that thyroid loves iodine because thyroid hormone has 4 atoms of iodine for T4 and 3 atoms for T3. So iodine is very important. And if you are hyperthyroid and you haven't yet started on thyroid replacement, you don't want to add iodine sources because they will be like adding fuel to the fire. They will make things worse. So your iodine-containing products like kelp, cod, fish, and some other fish, avocado apparently has a fair amount of iodine, and many other products. So we want to watch for those and not overdo it. On treatment, that is not as big of a problem. In fact, it could be totally fine. But when you think about issues with autoimmunity, you go by your autoimmune version of a diet that you prefer for that. What diet do you prefer for autoimmune patients?
So I definitely want them to avoid sugar at all costs, definitely. And more like unprocessed foods like Whole30 and definitely dairy-free, gluten-free, as little inflammation,
Yes.
extra as possible. And definitely sweets, because yeah, I think people that were used to eating, I can eat anything, right? A lot of them have a lot of sugar and processed foods and carbs, generally speaking. And again, that's just, of course, they're going to gain weight when they, and cause more inflammation when
Correct.
their thyroid gets treated.
Yes, then that becomes next level of complexity. First level is we have autoimmunity, we want to cool down thyroid. And next level is not to regain the weight, because people are unhappy when they finally were losing weight, and here it is.
Yeah.
Yes.
Yeah. Yeah. So, have you, I think we spoke at some point before about like cellular inflammation and how sometimes maybe more like towards hypothyroid, like underactive thyroid. You can have normal or even high levels of hormones floating around, but because of cellular inflammation, that hormone cannot actually act because of the proper action, right? And transmit the proper message so that your body does not respond to that. Have you seen that?
Yeah, so it's almost thyroid hormone resistance, and there are different, you would say, different degrees of thyroid hormone resistance. There are cases that actually describe not because of inflammation, but because of genetics, and they could be on level of pituitary, on whole body level, and then they have very strange set of blood tests where they will have high TSH, and they have normal high TSH and high T4 and T3, and at the same time they will have symptoms of underactive thyroid. Those are rare, and those are, as I said, genetic cases. There are some degree of acquired cases of similar issues when you have some endocrine disruptors that can interfere with function of thyroid hormone and kind of cause very similar picture. And then you have to find out what is the toxicity and how to deal with that and how to improve person's condition. Yeah.
Mm-hmm. Do you recommend toxic substance levels for some patients?
Yes, I do.
With hyper.
Yes, I do check certain chemicals. I always try to ask about exposure to different chemicals, to heavy metals, to mold, because all of those can be interfering with the function of thyroid. And there are certain chemicals that specifically known as thyroid endocrine disruptors. There are more known estrogen and testosterone endocrine disruptors, but thyroid endocrine disruptors exist and described as well. And therefore, we need to be aware of that and think in a bigger picture, not only just here's these particular abnormal levels of thyroid hormones and what to do about them.
Mm-hmm. Right, right. And do you, generally speaking, now talk about salt.
Yeah.
Do you recommend Himalayan salt? Do you recommend sea salt? Do you recommend the regular iodized salt?
I don't necessarily tell them which salt to have, but I check their levels. And I noticed that about a quarter of my patients have iodine deficiency. And if they are deficient, we will supplement that. And I'm not a big proponent of very high iodine levels or high iodine doses, because I've seen people who came to me after starting those huge iodine doses, like 12 milligrams, and they have developed either hyperthyroidism or hypothyroidism because of those high doses. And therefore, I decide that I will use gradual increase of iodine in my patients, something like your normal daily dose for non-pregnant is 150 microgram, and for pregnant is 250 microgram daily. And therefore, I start with 250. If I know a person is deficient for a couple of days, I will do 250. Then we go to 500, 750, and 1,000. And I stay at 1,000 for 5-6 weeks, and then we'll do 1,000 once a week. Our thyroid holds iodine for about 6 weeks. And if, for example, today you stop any iodine, in 6 weeks, it will be empty. And knowing that 6 weeks rule, I try to stay ahead and give them about 1,000 microgram weekly. And that keeps their levels good, not too high, not too little, usually quite optimal. Again, it's interesting with supplements, you always want to check what people take, because they could take 10 different things. And even if each of them has tiny amount of iodine or zinc or calcium, magnesium, or whatever it is, at the end you may end up with triple or quadruple of upper normal limit, and it's not always very good. For example, with high iodine, not only it can affect the thyroid, but it can create acne. And I had one case where a person was very diligent in taking her iodine, and somehow she ended up actually with high levels. And she developed acne, which were completely gone after the iodine was stopped. And level drop to normal limit. Yeah.
Wow. Interesting.
Yeah.
Very interesting. Super, super. And then the general approach is with medication, right, for hyperthyroidism. But I see a lot of people that probably 10 years ago or so had the radioactive treatment, and now they're, I have a underactive hypothyroid, everything is burned. So when do you recommend the medication, and then when do you go to for the radioactive?
So we always have a discussion, and my discussion goes something like that, it's very cultural. And for example, I'm from Russia. Russian approach is to have surgery. In yes, in
For
Europe,
hyperthyroidism? Wow.
hyperthyroidism, they prefer to do surgery and be done. With Europe, it was always mostly medications, anti-thyroid medications like PTU or methimazole. And the United States traditionally was mostly radioactive iodine. And each of them have plus and minuses. And we have to remember that Graves' disease in certain percentage of people will be associated with thyroid eye disease. You may have seen people who have protrusion of the eyes, stare, and other eye symptoms, inflammation. Severe cases could lead actually to blindness. And in cases with thyroid eye disease, radioactive iodine actually is worse. It will make eye disease worse. And if person is a smoker, they will have high chance of developing eye disease later on or soon enough. So because of that, smokers, eye disease already present, they're not best candidates for radioactive iodine. Plus, what else is important to remember, that people on anti-thyroid medication have about 40% chance of remission. And for me personally, I would take that. I would take that chance that after a year or two of taking medication, my body may recover and I will not need any medications, because otherwise we know for sure that radioactive iodine in most of cases will lead to underactive thyroid, and people don't tolerate that really well. And of course, surgery can be an option for some people who, for example, don't tolerate medications, don't want to have radioactive iodine, or may want to have resolution of symptoms relatively quickly, like women who want to have pregnancies. We don't allow them, it's not allowing, but we suggest them to avoid pregnancy for a year after radioactive iodine surgery or radioactive iodine ablation. But if a woman is in a hurry, wants to get pregnant soon, and doesn't want to expose her fetuses to anti-thyroid medication, they may choose to have short term of anti-thyroid medication, just enough to cool down thyroid, and have surgery. And after that, they will be underactive. But we have a lot more data of safety of thyroid replacement therapy for pregnant women and babies versus anti-thyroid medication, even though we have fair amount of data with methimazole during pregnancy, and that's our medication of choice for pregnancy. Take it back. PTU is actually preferred. Methimazole could be used during second or third trimester, but not the first trimester. Sorry.
Yeah, I have several patients that they're still they're not yet off methimazole, but we're able to drop the dose significantly, and they feel fantastic. So yes, and nobody developed any eye disease. So it's definitely, yeah, it's the best way. Yeah, totally. I would not do surgery or radioactive iodine if I could help it, if I had this problem myself. So
Correct. Yes, surgery is the last resort.
last resort, always, right? We
Yeah.
want to do everything conservatively as much as possible until before we,
And with the
reach out to invasive.
radioactive iodine, unfortunately, has a long-term effect that there might be more cancers in the area down the road, in the surrounding tissues. And that's another why I personally wouldn't do radioactive iodine if I can help it. So
Yeah, absolutely. Wow, this was super. This was excellent, very informative. Definitely learned something new today. So I hope everybody else did. And we want to encourage everybody to post the comments below and to tell us if they liked the video, if they found it informative, and what other subjects they would like to have us discuss about in functional endocrinology.
yes.
Thank you so much.
Thank you. Bye-bye.
Okay.